Friends, today we will discuss about sandwich appearance of gallbladder wall, where three layers of gallbladder wall are easily visible on ultrasound, which is visible as a single layer normally. The sandwich appearance of gallbladder wall is seen in inflammatory conditions like acute cholecystitis and non-inflammatory conditions. Let us discuss about it. In case of acute inflammation, gallbladder wall is thickened and distended. Normal length is up to 7 to 8 cm. More than 10 cm is abnormal. Normal diameter is up to 3 to 4 cm. More than 5 cm is always abnormal. That is distended gallbladder. Normal thickness of gallbladder wall is less than 3 mm. 3 to 4 mm is borderline and more than 4 mm is always abnormal. In the other word, you can say in distended gallbladder, the length should be more than 10 cm, diameter should be more than 5 cm and wall thickness should be more than 3 mm. Regular and symmetric increased thickness of gallbladder wall is in favor of inflammation. Irregular and asymmetrical increased thickness of gallbladder wall is in favor of malignancy. In case of inflammatory gallbladder, the gallbladder will be distended. Length should be more than 10 cm, diameter should be more than 5 cm and wall thickness should be more than 3 mm. Length should be measured in longitudinal section and diameter should be measured in transverse section. In normal gallbladder, three layers are not seen on ultrasound, which is seen in inflammatory cases. In reverse, you can say three layers are distinct in inflammatory gallbladder due to collection of fluid inside. In this slide, it is not an inflammatory one as three layers are not distinct. As I have already told, regular and symmetrical increased thickness of gallbladder wall is in favor of inflammation. Irregular and asymmetrical increased thickness of gallbladder wall is in favor of malignancy. In case of acute inflammation, wall thickness should be more than 3 mm. Gallbladder wall thickness should be measured from outer hypoechoic line to inner hypoechoic line as in figure. Let's discuss certain conditions where there is increased thickness of gallbladder wall. Those are inflammatory conditions like acute cholecystitis, chronic cholecystitis, acalculous cholecystitis, xanthogranulomatous cholecystitis, gallbladder carcinoma, and adenomyomatous gallbladder. Remember, there are certain non-inflammatory conditions which leads to increased thickness of gallbladder wall, where it is called as a reactive increased thickness of gallbladder wall. Those are ascites, congestive heart failure, renal failure, hepatitis, AIDS patient, and liver cirrhosis cases. These are the non-inflammatory conditions where there is increased thickness of gallbladder wall. Sandwich appearance of GB wall are seen in inflammatory conditions like acute cholecystitis and also seen in non-inflammatory conditions. Those are liver cirrhosis, ascites, hepatitis, congestive heart failure, renal failure, and AIDS patient. Gallbladder wall has three layers. Outer one is serosa, middle one is muscular layer, and inner one is mucosal layer. These three layers are distinct. That means clearly visible on ultrasound in inflammatory conditions like acute inflammation and certain non-inflammatory conditions as I have mentioned. Let's discuss whether it is due to inflammatory or non-inflammatory conditions. Normally or in normal gallbladder, three layers are not distinct. That means three layers behaves like a single layer on ultrasound, as in figure. But in acute inflammation and certain non-inflammatory conditions, these three layers are distinct. That means clearly visible on ultrasound, which is called as a sandwich appearance of gallbladder wall. This slide with longitudinal section of gallbladder shows sandwich appearance of gallbladder wall, where outer layer is hypoechoic, which is due to serous layer. Middle layer is hypoechoic, which is due to muscular layer, and inner layer is hypoechoic, which is due to mucosal layer. This slide with transverse section of gallbladder shows sandwich appearance of gallbladder wall, where outer layer is hypoechoic, which is due to serous layer. Middle layer is hypoechoic, which is due to muscular layer, and inner layer is hypoechoic, which is due to mucosal layer. Sandwich appearance of gallbladder wall seen in both in inflammatory and non-inflammatory conditions. Let us discuss how to distinguish between these two. Sonographic features of acute cholecystitis are: first, presence of thickened gallbladder wall which is more than 3 mm. Second, presence of pericholecystic fluid. Third, presence of sonographic morphine. Fourth, presence of gallstone. Go through my previous videos for details. In acute inflammation, on taking the help of color box, gallbladder wall will take color. Due to inflammation present, it will cause hypervascularity, as in figure. Let's discuss how it differs from non-inflammatory conditions. These are the non-inflammatory conditions where there is increased thickness of gallbladder wall. It is otherwise called as a reactive increased thickness of gallbladder wall. Those are ascites, congestive heart failure, renal failure, hepatitis, and AIDS patient, which I have discussed already. Let's discuss what are the sonographic features in its favor. First, due to absence of inflammation, it is absence of sonographic morphine. What is sonographic morphine? You please go through my previous video. Second, due to non-inflammatory conditions, on taking the help of color box, there will be no sign of hyperemia of gallbladder wall. That means gallbladder wall will not take color, which is present in acute inflammation. Third, search for its cause. Why gallbladder wall is thickened, that is more than 3 mm, with sandwich appearance without any gallstone. Most of the cases it is due to non-inflammatory conditions. At that time you search for free fluid inside peritoneal cavity. Figure shows free fluid inside peritoneal cavity and in between bowel lobes. Figure shows free fluid inside peritoneal cavity and hepatorenal pouch, which is a dependent part in supine position. Fourth, do renal scan, and most of the cases cortex medullary differentiation is not maintained. That is, cortex medullary differentiation is lost in non-inflammatory cases. This slide with normal renal scan shows cortex medullary differentiation is maintained. Normally, cortex is hypoechoic on comparison to liver parenchyma and medulla is hypoechoic on comparison to liver parenchyma. This slide with abnormal renal scan shows cortex medullary differentiation is not maintained, that is lost, which is in favor of non-inflammation. Thank you. Thanks for watching.